Good morning and welcome. Happy Easter to yet another session of Chai and Why. Today, of course, we are dealing with a topic that involves each and every one of us. All of us have been affected. We are all worrying about what is happening with COVID-19, especially in India, especially in places like Mumbai. And to tell us about this, we have Professor Sandeep Juneja. He's the Dean of the School of Technology and Computer Science at TIFR. And he's not a medical doctor. He's not an epidemiologist. He works in applied probability. And he wanted us to make it very clear that he works in probability, in machine learning, mathematical finance, Monte Carlo simulations, etc. And he has been involved in modeling the COVID-19 spread in Mumbai with the group in the School of Technology and Computer Science, and in the mathematics of these epidemiological models. So over to you, Sandeep, and let's figure out what's happening with COVID-19.
Okay, good morning, everyone, and thank you, Arnab, for inviting me. Okay, so we'll just give me a moment. Let me just keep this out. Okay, so this is, when I gave this title, I thought I'll talk more about mathematics. But given that the numbers are rising, there's much more interest perhaps in understanding what's going on in Mumbai and, from the mathematical lens. So I'll devote considerable amount of time on Mumbai and what our model says and how to read what our model says. You can see this line, jara hatke, jara bachke. So, this was in 1956, continues to be true for Mumbai even now. So one needs to be very careful going forward, at least for coming some time. All right, we built a simulator. This was March last year when COVID was taking off. And we heard of the work by Ferguson and team in Imperial College, which was guiding the UK government and US government. So we all started thinking of building a simulator in India, and we tied up with our colleagues in ISC, and then over the next couple of months, we built this simulator. Key people in ISC, Rajesh Sundaresan, is a professor there. He was guiding this effort. In TFR, my colleagues, I have all the names here, but my colleagues Prahlad Harsha, Ramprasad Saptarishi, and Piyush Srivastav were keen in designing this simulator. Last many months, Daksh Mittal, who's working with us, but who's employed by IDFC Institute, so IDFC Institute is helping us in that manner, has been working very hard on current simulation analysis efforts. So I thought I'd mention him particularly because he's been very active in this effort. Okay, now this is going to be, it's one of those movies where you start at the end and then you go in the middle and then you kind of jump around. So it's a little bit like that. But I'm going to first start with just a review of the current COVID situation. And then I'll jump right into what our model is saying about Mumbai, how to absorb it, how to understand it. Some successes we had, but then some frustrations that are ongoing right now. This is not the time where one can do too much modeling. I think we just want to make that clear. And then I'll go ahead and, motivate, this is for the students particularly, what is mathematical modeling? Mathematical modeling is all about building assumptions and drawing conclusions from the assumptions. That's your theorems. Now, mathematicians typically enjoy the latter part. Assumptions are well known, hard problems, and you want to solve them through deductible reasoning. In the real world, a bigger challenge is coming up with the right assumptions. So I'll talk about this kind of relationship that's, this combination that's needed in mathematical modeling. And then I'll go ahead and talk about mathematical models as they are used for modeling COVID spread. So some of the models, but I'll be moving on to agent-based simulation model that we have been working on. Now, what's interesting about agent-based simulation model is that when you start a run, and this is for Mumbai, you have 13 million agents. Every person is an agent in Mumbai. So it's very detailed. You can see a lot more about the city because of that. But it takes forever. It takes 4 or 5 hours for one simulation run to happen. And you need to run many. There's some stochasticity. You need to run many of these. So then the question is, do we understand the underlying probabilistic structure well enough to exploit that and do everything much faster? So I'll say how to use a 500,000 people or 1 million people model to predict accurately for 13 million people or larger. So I'll give you some ideas. That's if you know that we'll see how that goes. If we had time, then I'll talk much about it. Otherwise, I'll outline those things quickly. But that's an area that we are completely excited about. It's kind of technical things that we typically do in our research. All right, but now let's come to the COVID situation. So as you know, COVID is just one second. So, I mean, we are, of course, seeing a lot of growth in India. India is now having the largest number of cases per day. Earlier, it was US and Brazil, but we know that COVID is also very rampant in Europe. So US, you've had about 30 million cases already. India, it's 12 million. Brazil was also it's very close to India, 12.9 million. These are a few days ago, so numbers may have increased. This is yesterday, actually. And then France and Russia and United Kingdom. So it's widespread and it continues to grow. That's something we, of course, now know in India, that the second wave is very strong. So this is, the Indian numbers, cases per day, and you can see that the second wave has started. It's focused on some states, but it's hard to imagine that it won't go to other states and it won't be strong there. So these numbers are likely to rise. This is fatality numbers here, and you can see that they've also started rising. Fatalities generally lag cases. A case typically takes maybe 18 to 20 days, 2 to 3 weeks, maybe a little bit longer. If it doesn't work out for the person, it takes that much time for the case to, for the person actually not to make it. These are COVID tests. So they were, I guess, around 1.2 million earlier. Then they were coming down, and now they're going back up again. The COVID tests have to increase, I guess. That's the only way you get to find out about the disease and control it. By the way, all feel free to bring in your comments. I may not be able to see chat so much when I'm chatting. Yeah. All right, but yeah, I will be looking at the chat as well. But otherwise, if you want to speak in, we'll see. I mean, at least initially we can try that. So please feel free to jump in. State of infections. So Maharashtra, you can see here that cases are growing and fatalities have started to grow. Let me erase this. Punjab is following in a similar manner, right? So again, this is February here. So this is cases on this axis: 500, 1,000, 1,500, 2,000. Fatalities are on this axis: 20, 40, 60, 80, 100. Fatalities are in yellow line and cases are in purple line. So you can see for Mumbai, the cases had gone up to about 2,500, 3,000 in the earlier wave, but the fatalities, well, this is Maharashtra, sorry. So 25,000, sorry. I'll come to Mumbai in a moment. So about 25,000 thereabouts. But fatalities were here. In the relative sense, in the cases versus fatality, the ratio seems to have changed. Now, per case, you're seeing lesser fatalities in Maharashtra. And that's somewhat true, though not so much in Punjab. It looks very similar to where things were. Cases are also rising in Gujarat, in Madhya Pradesh. Kerala, they have been high for a long time. So they were hovering around 6,000 cases per day. Now they were coming down, but there's a slight uptick. So we have to wait and watch. You can see in Chhattisgarh also cases and fatalities both have begun to rise. So these are some of the states, so infection of states. So in Karnataka also you're seeing a small rise here. In Rajasthan, you're seeing a small rise here. This could take off. UP, Tamil Nadu, West Bengal, Haryana. So all over India, cases have begun to rise. So it's a cause of huge concern. You can see that the earlier peak for India was around September, because for the big states, it was around in September. All the big states had a peak around that time, maybe except for Kerala. So that would, India is basically a combination of these things. So if other states are peaking around September mostly, then overall peak will also be around that time. So you can see for Karnataka as well, the peak was around September. In UP, also peak was around September. So because of these reasons, you saw a peak in September in India earlier, and we'll probably see India-wide peak as well as, we are seeing it right now as we go forward. Let's look at infection levels in district of Maharashtra. So this is interesting. This is Mumbai right now. So you can see that the cases earlier were hovering around 1,500, 2,000. This is May, June, July last year. Cases were low because testing was very low. By September, the cases went up to almost 3,000, about 2,500 thereabouts. And now they're much, much higher because we're testing much more than at that time. Well, that's one reason. Fatalities vis-a-vis cases, they went up to, I guess, 100, 120 per day. And, so they were much higher in proportion to the cases. Right now, they are much lower in proportion to the cases. Now, cases, as I mentioned earlier, are leading indicators of fatality by 2-3 weeks. So some of this gap may close as we go forward. But nonetheless, I'll talk more about this gap later. But you do see that case fatality ratio, that's number of fatalities that you see per case, appears lower right now. And we'll talk about that later. This is for Mumbai. Pretty much similar thing you see for Thane. So again, around February first week, the numbers start to peak, and they're peaking about the same. So in Mumbai, you're seeing about, according to this graph, this was a few days ago, 6,000-7,000, but I guess now we have gone to 9,000 cases. In Thane, around that time, you were seeing about 4,000 cases. In Pune, at that time, you were seeing around 8,000 cases. This is a couple of days ago, but otherwise very similar. Pune is behaving in a very similar manner to Thane and Mumbai, and Nasik is also increasing. So very similar trends, very similar kind of rise. Nagpur is another place that has risen around the same time, slightly earlier. And Amravati is an interesting case because it increased here. It actually increased before, Mumbai and Pune and all took off. And the reason people tell me is that, in all of these places, essentially what's happened is that, when the numbers started coming down in November, December, January, people became more lax because the sense was, okay, now we have enough immunity in the system. There's some kind of herd immunity is set in. So the risk is very less, and people had generally had there was lack of compliance to rules and regulations, wearing masks, social distancing, etc. But that was apparently true in Amravati more so in January. Apparently there were some weddings and all of that, and schools had opened around late Jan. So
Sandeep,
yes.
Sandeep, there's a question. Where are you getting all this data from? Can you tell us the source of this data?
Yeah, so this is from covidindia.org. Sorry, I should have mentioned it. I just didn't have space here.
Okay, I'll put it in the chat. Don't worry.
covidindia.org. Right. But I mean, that's interesting to note that, Amravati actually had cases earlier than the rest of major cities in Mumbai. And because there was a lockdown, you actually see the cases coming down there. Okay, so why are the numbers rising? So the big answer is we don't know. There are a number of reasons, but we don't quite know how much is which reason contributing to what. And it's not clear that we understand all the reasons fully well. But let me just give you some feel for this. So mutation and variance could be one reason. Sorry. So 10,787 samples from 18 Indian states showed up 771 cases of known variants, 736 of the UK and 34 of the South African and 1 Brazilian. All right. So variants may have begun to play a role. We'll talk about variants a little bit more later. That, the interesting thing about variants is that even suppose they enter the country, say November, when the cases are generally declining, then they're not going to increase very fast, although even if they happen to be more effective than the prevalent strain. On the other hand, when the economy opens up, when certainly intermixing happens, then their rate of increase is quite fast. So these numbers where you see small numbers of variants can actually blow up when the overall infection is growing. Double mutation, a separate lineage developing in India with, so again, these are medical terms, so I won't talk much about them, but L452R and E484Q mutations coming together. And that's been linked to 230 cases in Maharashtra. Main reason may well be COVID inappropriate behavior. You become lax and you think it's okay because infection is going down, but suddenly some opening up happens and that gives avenue for infection to take off. At that time, laxness really leads to explosion in infections. So this could be a major reason according to us. And one where this shows up is in social gatherings. So we've seen that all over India, Gram Panchayat elections, marriage season, opening of schools in some parts, festivals and opening of public transport, religious and social gatherings. So all of these are places where a lot of gathering of people happens, and these could be super spreader events. Okay, now what we again don't know much about is reinfections. Are these causing, people who were infected last year in March, April, May, are they beginning to get infected now? So we don't really understand that very well. Even if they are getting infected, is it a serious infection or is it a mild infection? If it's a mild infection, okay, that's a very different story. Unrestricted mobility. So within urban areas, people are traveling a lot more than before. So that means the disease also travels a lot more. Urban, rural transportation, cross-state travel. And this, of course, testing, tracing, and isolating is one way of controlling the disease. So if you're not doing that enough, then it will spread. Okay, now let's talk about some data. So let's look at Mumbai shifted case fatality ratio. So what's a case fatality ratio? It's, as I mentioned, number of fatalities per case, right? And we shifted because cases occur now, and that may result in fatality maybe 2-3 weeks, a little bit longer than that even later. So I have this graph here, case fatality ratio of fatality upon cases, summed over 36 days. 36 actually is taken, this graph was made a few days ago because I wanted to measure the trend from February 10th, and I needed 18 days of shift between the last case and the fatality. So that left for 36 days that I could average the data for. So that's what I did. So I go back with that and you see that, okay, the case fatality ratio shifted, was around 3.5% or so in August. And it's been steadily coming down. And now it's more of the order of 0.8% or so. So that's an interesting thing about Mumbai, that the case fatality ratio has been coming down. This is what you see, BMC also mentioned a lot in the newspapers. Having said that, the fatalities have suddenly started rising in Mumbai last couple of days. We saw 27 fatalities yesterday. So that's very worrying, because when you see 27 fatalities yesterday, and then you go back 18-20 days, around 18-20 days, I guess, so you're looking at somewhere maybe around here. At that time, the cases were more of the order of 2,000. So around 2,000 cases are already giving you plus 20 fatalities. So you have to worry what will you see in this region. So anyway, that's quite worrying actually, because it's also just jumped up. It was just a few days ago, it was more like 10, 12. Okay, so what are the possible explanations for this case fatality ratio coming down? Improved care can be one reason that we are taking better care of people now than in August, although probably not that much. We had learned a lot in August already. Presence of mild reinfections could increase the number of cases without resulting in fatalities. So that would be one reason. There could be a more infectious strain. So we are seeing a lot more cases, but those cases are not resulting into fatalities. So not more deadly, maybe less deadly. So that could be one reason for this. But I think the most reason to me is that more testing is going on. And that's because population segment that is getting exposed now is more likely to get tested. So, so early on, for example, we saw this. So we had conducted this sero survey in Mumbai in July. And, you looked at so we conducted this in 3 wards in Mumbai. And you estimate how much population is infected in the slums of those 3 wards. And then you compare it to how many cases you saw in the slums of those 3 wards. And you conclude that, okay, maybe for every 100 infections, 1 case actually gets reported. Massive difference. Every 100 people have to get infected, and then one person has such severe symptoms that they go to the hospital to get tested, it turned out to be positive. Now, in the non-slums, we saw this number was much better. It was one in 16, 17. So 16, 17 people get infected and 1 case comes out of it. And presumably what's going on now is, the infection is going deeper into people who are more cautious earlier, or who maybe lived in more spacey places. So now these could be people who, if they see slight symptoms, they get tested faster. So it could well be that for every, maybe 5 to 10 infections, you see 1 case. So that would already, for same number of infections, and hence on average, because infections and fatalities are proportionality related. So for same number of fatalities, you'll see more cases. So that to my mind is a very strong reason for why we are seeing this low fatality ratio. But it's good not to take too strong positions at this time. Let's observe and see. That's the message for now, because too much is going on.
Sandeep, a question from Facebook from Aritra. He's asking, is the testing how is the testing numbers increased? Are we testing more right now? I mean, compared to like testing per, I guess,
Yeah,
per
so
population or something.
sure. So that's true. I have not really put in the slides for that. So testing, I guess, some time ago, not long ago, has increased from, we were testing about 20,000 thereabouts till maybe a week ago or so, maybe a little bit before that. And now it's more in the range of 45, 50,000. So there's more random testing using that antigen testing is going on in some places. That's led to increase in the amount of testing. So we are doing about 45 to 50,000 tests. What's interesting is that about 70% of those tests may be RT-PCR tests. Very likely this is, when you are feeling symptoms, you go to the hospital. At that time, you want to get an RT-PCR test done. Positivity is going up. So positivity of RT-PCR tests is of the order of 30%, 35%. This used to be about 5%, in January or December. So that's telling you that the infection is very prevalent. So, so testing has increased, but still, it's capturing also a lot of positivity. So all of this is a sign that infection is highly prevalent right now.
Okay, and there's another question from Sanskar Agarwal on who's asking, how about vaccines which have sort of less infection? They don't protect you against infection, but they protect you against mortality. So hence the fatalities are low because of the vaccination, or is it too few vaccines as yet to figure out if vaccines have any effect?
Sure. So we'll talk more about this, but you can see that most of the vaccines in Maharashtra to elderly, because elderly people lead to much more fatalities, happened in the month of March. I think about 5-6 lakh people. So now you say, okay, let's say maybe the average date of that time was say March 15th, and the vaccine takes at least 2-3 weeks before it even begins to be effective, right? And it has some efficacy of maybe 70-75%. And if it were to be effective, so give it to 2-3 weeks, so it's becoming effective in sometime in April, then it takes a month to save a person from fatality. So all of this will begin to see in May in data. The improvement due to vaccines most will start to be seen in May, not right now. So that's an important point to keep in mind. So vaccines are the way forward. Vaccine. No, it's okay to have questions in between. I think it's a great idea. Yeah. Because Arnab has given me much more flexibility in when to close. So I think it's probably good to have it interactive. Now, one reason one could have thought was maybe it's that younger people are getting infected now. Younger people are socializing, they are partying a lot more, and that's where infections are happening. So these are cases, but not really fatalities. But if you see this data right here, this is from November, bi-weekly data. We just picked up the data from the dashboard, and we count the fraction of cases divided by the age. You see this fraction is changing very little. There's been some increase, in younger people getting infected. This is percentage of the infection. This is absolute numbers of infections. So absolute numbers we know have been growing since mid-February, thereabouts. But if you see a percentage of infections, that age group has not changed very much. So this is not going to explain the high CFR, the decrease in CFR. Okay, any further questions on this?
No, I think just go ahead.
Okay, sure. So India currently has 2 vaccines, Covishield, that's from AstraZeneca with Oxford University, which supposedly has 76% efficacy. These are all limited data. They had a lot of error around them. So, just, don't have too much faith in these numbers. These are just ballpark numbers. Similarly with Covaxin, they had interim efficacy of 81%. But these are good numbers, and as we've been seeing, they do seem to be preventing completely against mortality. So that's a very good reason to go for vaccines. So, I think one advice to give to anybody is that, if you get infected now, your risk of mortality is of the order of, especially if you're older, is of the order of, 1 in 200, 1 in 100 thereabouts. But if you take a vaccine, any kind of serious side effect, you're looking at of the order of maybe 1 in 500,000 or so for serious side effects. This was, I think, I guess 7 fatalities out of 18 million that were seen in UK. So extremely small number. So, just weigh the two, and it's very clear that you should get vaccinated. If you have a choice of vaccine, okay, then you decide which vaccine you want to choose. That's another issue. But getting vaccinated ASAP, it's a no-brainer. One should go for it immediately. Okay, so vaccinations were launched on January 16th for healthcare workers and frontline staff. March 1, 2021 onwards, people over 60 years of age and people between 45 and 60 with severe comorbidities, for them the vaccines became available. And April 1st, just a few days ago, people over 45 years of age can get vaccinated. The goal is of reaching 250 million by July 2021. That's a bit ambitious. That requires 3.5 billion doses per day. So that's a major ramp up from where we are right now. India has exported more than 60 million vaccine doses to 76 countries till date, and that's primarily Covishield. So these are just some facts. This is a graph from March 28, so it's about a week old. So India has a population of about 138 crore, and about 6 crore people were vaccinated in India about a week ago. You can see that the pace was slow. It's picking up, but needs to pick up much more. Maharashtra has a population, no, that's not right. Oh yeah, 11.42 crore, that's correct. And it had 58 lakh people vaccinated, so slightly higher percentage than all over India. And Mumbai has about 12.8 crore population, that's Greater Mumbai, and 11.2 lakh were vaccinated over a week ago. So again, slightly higher fraction compared to the rest of India, but has to go much more than this. Okay.
Two quick questions.
Okay, so now I'll talk about the findings of our, yes.
Before we get into your simulator, so the question is, if you get vaccinated, will you test positive in an RT-PCR test? And does the vaccine give you basically a COVID infection or not?
So I think there are many cases now, there are quite a few cases now coming up of people testing positive after they've been vaccinated. I mean, that's the whole point of this efficacy. Efficacy is 75%, say. But, a few weeks after the first dose, efficacy is much lower. Could even be less than 50%. So all you've done is you reduce the chance of testing positive by 50% thereabouts. But, still a substantial number of people will get tested positive. Hopefully, even then, severe symptoms will be controlled. I think that's the expectation. That's from the data that we've seen so far. What was the other question? Sorry.
So, I mean, does the vaccine give you an infection is the question.
No, vaccines work on a different principle. So they don't give you an infection per se.
Okay, and there are questions on, since the fatality is low, should lockdowns, but I think let's look at your simulation before we talk about lockdowns, right?
Right.
Yeah, we'll come to lockdowns later.
I mean, I'll just tell you very quickly that, if the government is running out of ICUs and oxygen cylinders, then they have to think carefully about slowing the city down. Because otherwise, you will have excess mortality, because a lot of people won't get the medical care that they need. So that's a severe situation. On the other hand, there are costs to lockdown. There's a severe economic cost. So I don't have all the data to kind of play with the trade-off. So, but these are the trade-offs that the government has to kind of decide upon. What are the economic costs and social costs vis-a-vis the very clear costs of patients not getting enough healthcare. So these things have to be considered. Let me come to the model. Some of these issues I'll come to as we go along. So this was, this is our October report. This is on our website. You can see it. And as for the October report, we had modeled that transmission. So I'll get into details of our modeling later, but I just want to talk about some high-level things. The transmission rates was 3 times higher in slums compared to non-slums. So we modeled it that way. That was our input parameter. And we did that because we wanted to match the sero survey data from Mumbai for the 3 wards. And what we see is that, sero survey was basically testing people on July 1st. So you see here, okay, 56% people in slums are infected, about 16% people in non-slums are infected. So it's a very good match to what we actually saw in the sero survey in Mumbai. So that's why we thought, okay, these parameters that we have to kind of come up with should match the data, and they are matching the data. So this was a key parameter. So this is saying if you believe this and this was our model projection of how the slums are going to increase in prevalence. So this is prevalence in slums over time. So in December 1, for example, we are seeing about maybe 80% people in the slums are infected, and then not much changes for a while. For non-slums, you can see that maybe 60% of people are infected by February 15th. So that's what this is saying right now, as per the model. As how will the disease progress over time? This is how it comes up with. It was not a bad prediction. In October first week, there was an independent sero survey done in some slums, which found 75% people infected. So you can see that, it's kind of matching quite well here. And then, people getting tested for seropositivity in clinics and all, they were reporting on 40, 45, 50% positivity around October, November. So, it was it was not a terrible, it looked like a reasonably good model, and model one can it can be off, but maybe not by that much. Right. But even with this, even if this was to be kind of true, sort of true, it'll never be exactly true. But even if this was to be kind of true, there will be pockets where the infection will be very low. And even if you say 60%, for example, in non-slums, in 13 million population, that 6.5 million population is roughly in non-slums, in buildings, etc. 40% of that is a huge number. Right, that's of the order of between 2.5 and 3. So that's still a large number of population that can get infected. And then there are pockets where where a lot of people are susceptible. So even with these numbers, the kind of wave that we are seeing right now is not surprising. It's under conditions that we'll see, it makes sense. Okay, but let me talk about what our model predictions were saying. Let me say right now, this is what it said in October. Because October was a much better time, and before that was a much better time. We don't really worry about reinfections. We won't worry about variants. There was more it seems that now in retrospect, it seems that there was more predictability in the system. We understood the system better. So let's look at this picture here. This is a picture of fatalities, simulated number of fatalities. So you can see the fatality numbers here. You can see the dates here. These red bars are telling you actual number of fatalities seen. Right? So these are actual data that we saw right up till end October, towards the last week of October. And then all these other curves that you see are the results from our model simulation, what they think is going to happen. And what's nice about this model, as we discuss later, is you can play around with the things. You can say, okay, what will happen if I open up the economy November 1st? That's what's being captured here. Or what will happen if I open up the economy on January 1st, along with the trains? So that's being captured here. So these are things we can do. Let me just tell you something about the kind of assumptions we had built into our model. So we had assumed that lockdown till May 17th, just capturing the reality. Limited mobility to community work, masks, everyone's wearing masks, home quarantine, case isolation, etc. This is all that happens in the lockdown. Masks started around April 9th. That's when they were mandated. Containment efforts, contact tracing is in place. So all of that is also being captured by our model. Compliance, we assume, is 60% in non-slums. So 60% of people are actually complying to the rules and regulations. What that means is that they are wearing masks when they go outside. If they're told to home quarantine, then they do home quarantine. Most of them, one can specify how many. If they are told to isolate, most of them isolate. Again, one can specify how many. If they're non-compliant, then these numbers change. So again, attempt is to be kind of model reality, and 40% in slums. And the idea is slums are very crowded, and it's very difficult to be compliant there. Mobility to workplaces was set at 5% mid-May, increased to 15% in June, 25% July. So this was in line with how Maharashtra government was allowing the city to open up. So we kept numbers to match that. And we got, as per our, I guess we had an August report, it did a pretty good job of predicting how the fatalities will come out. But, we were not really, clued into the city per se. So at that time, we didn't anticipate that Ganpati would mean that a lot of people will come and there'll be a lot of mixing, a lot of interaction. So we learned from that. So this peak here, I guess this should be around August, September. So this peak here was essentially because of Ganpati. So this we learned from, and then we kind of adjusted that in our model for future. Next time there are holidays, etc. We figured out how much interaction happened during Ganpati per day, and we asked ourselves if similar interaction happens during Dussehra or Diwali or Christmas, how would the cases rise? So all of these things we did. Few more things to mention here. Yes.
There is a question from Gautam Menon. He's asking, what is your assumed IFR, and are they age stratified?
Right. So we don't assume IFR. It's an output from the model. And in the model, we have, people get infected in a non-age stratified manner. But once you're infected and you have symptoms, you get hospitalized in a age stratified manner. So an older person has a much higher probability of being hospitalized, and older person has a much higher probability of requiring critical care after they're hospitalized, and they have a much higher probability of not making it. So all of this was taken from data from Verity et al. They had done this analysis in Wuhan in China. This was early last year. So we use that, and the net result of that is we get an IFR for the city. But basically, all of our work was about matching fatalities in Mumbai. So we really are getting, we're matching the IFR that Mumbai city observes. So I guess now, so your question can be, what was the IFR that the Mumbai city observed? So there's this whole issue of, okay, do you account for, this excessive deaths, or do you believe the fatality numbers as they're reported? So of this calculation for a while, but yeah, Wuhan data, if you were to use the age-adjusted numbers, would suggest a fatality IFR for Mumbai infection fatality ratio. So that's fatality per fatalities are on the numerator, infections on the denominator. That would be 0.2% thereabouts. So that would mean that I guess maybe 1 in 500 is going to not make it. So that was the IFR that the model suggested for Mumbai, because Mumbai is a young population. So it was that ballpark, and it becomes lower in the slums, because slums, when we did our sero survey, we actually did a survey of how old people were in each home, and that told us that slums are much younger than non-slums. So in slums, it would be more of the order of 0.1%. In non-slums, it would be more of the order of 0.3%. The actual numbers that we saw are not too far for that in Mumbai, except for the fact that, okay, how you account for excessive deaths. So if you see the actual fatality in Mumbai as reported, IFR becomes a little bit less, more like 0.15 thereabouts. But I'll have to check these numbers. I've not seen these numbers for a while. So maybe 0.1 to 0.15%. Is that okay, Gautam? Okay, sure. Okay, so with all of this, I just want to make a few more points. So we said that if you open the economy up on January 1st, now there's a reason why I'm showing a fatality graph to you. I'm not showing you the other graph that we also come up with. For example, cases, we don't even try to make graphs of, because cases are very hard to predict. Reported cases, they depend upon the policy. Suddenly now there's random testing going on using rapid antigen tests that changes the numbers. Sometimes you're short of, you're not testing that much. So it's enormously variable. And again, it also depends on the segment of population that's being tested, because they respond differently. They come forth with symptoms to get tested much differently. So cases are very difficult to forecast. So we don't try it, because you make all kinds of mistakes. Fatalities are a much more reliable number. So we try to forecast them basically. So that's why I'm showing you this graph. We could talk about hospitalization and critical cases, but fatalities are more reliable. So now let's come back to this picture right here. So now if we had opened up the economy on November 1st, this is an important point. You see a peak around December 15th, Jan 1st, about 2 months later. If you open up the economy on January 1st here, this is again our October report, then you see a peak in, I guess, around March 15th, thereabouts. Right? So, and between the valley, when the numbers start to grow, that's around Feb 1st to, let's say, I guess maybe April 1st is a better representation. It's about 2 months. So between the valley of fatalities, when you open up, to the peak of fatality, it takes about 2 months. So that's worth keeping in mind. This number would be smaller if you had opened up on November 1st, around here, because you have more susceptible people, less infected people at that time. So someone, I guess Kaushal says a question, could we guess the future rise of fatality and case per projection? So that's what we've been doing so far. Under current settings, I would not recommend that you try it. I think there's a lot that we don't know. Any effort at projection is going to go wrong. You can see here as well, we had projected in this picture, it's saying about 20 fatalities as a peak, while Mumbai is already seeing 27 fatalities right now, and the number is likely to rise. This was, of course, we had made a mention in our report with these numbers that, assuming that behavior of people does not change, that, the compliance levels remain 40%, 60%, We said, if you assume that, then you see this. Now, we could have at that time in October considered the possibility that compliance would be less at this time, but it's very difficult to kind of guess these things. And we didn't do any scenario analysis at that time. Perhaps we could have. At that time, you're more worried about, okay, how will things look like in the next 2 months? So we didn't kind of think about these things. But you can see that if indeed we had allowed people to, if we had modeled the scenario where people will become less compliant, then these peaks will go up. But these are things which is difficult to know at that time. That's why modeling is difficult. Because these are one of the challenges of modeling, that how do you make the right assumptions? Your model will give you the results, but you have to get the assumptions right. So how do you make the assumptions about what's going to happen in this time period? But now the uncertainty is not just how compliant people are, etc. Uncertainty is about, okay, do we have variants? Is there reinfection? Maybe something about mobility of people. So all of these things is kind of contributing. So in any case, these are the few points I wanted to make in this slide. Now, this is what we actually saw. So this is, what we had predicted, what we had projected, not predicted, through our model, late October. And this is what we actually saw. So, as far as modeling goes, when you do modeling, you're going to be wrong. So you just want to get the broad trends right. Are we going to go down? Are we going to be substantially down by the time it's January? So you can see that, our orange line, because economy actually opened up on February 1st. So it was not doing terribly badly. This trend, it was kind of following the fatalities. What you do see is that it was underestimating fatalities already in this setting when it happened, suggesting that maybe, one should have kept in mind that, okay, people will become less compliant at that time. That could have been an assumption one could have also put in the model. But nonetheless, this, I would say, as far as, modeling is going to be inaccurate, but by and large, it's not such a bad conclusion to come to. So this is matching up to February 1st. That's because even if you open up the economy on January 1st, till February 1st, it doesn't really affect the fatalities. The effect on fatalities takes about a month or so before it starts to show up. And that's what you see here. You see the rise here. So our model captures that as well. Okay, so some observations. So reasonably accurate match to observe fatalities. Match to hospitalizations I've not shown, and it's poor actually. And that's because we lack data on how much time segments of population spend in hospitals. So this data is not available to us. You can conjecture that, okay, people from, I guess, high density areas, slums and all that, typically would not spend that much time in the hospital. They can't afford to. They go there at the, when the disease is very severe. So they spend much less time. People who are more well off spend much more time. So because of that, depending on the mix, the hospitalization data changes. So unless we actually have the data from Mumbai, using Wuhan data is not going to help us. Wuhan data was made in a very specific conditions where hospitalizations happen when very specific criteria were met. So hospitalization critical cases, we were doing a poor job of matching. But for fatalities, we did an accurate job. And since we were calibrating to fatality, it seemed like that things were going okay. Also, we don't know what proportions of hospitals are occupied by patients from outside Mumbai. Typically, at least in July onwards, from the Thane district, a lot of patients started to come to Mumbai to get hospitalized. So this also adds another layer of uncertainty. So without data, in any case, one is, how do you make the right assumption if you don't have enough data? So that's always an issue. For fatalities, we have data, which is reasonably accurate. So as I said, model underestimates towards the latter part, maybe because compliance amongst the population is reducing. It could even be because more effective variants are present. We don't really know. The opening up of Jan 1 when translated to Feb 1 does a reasonable job of capturing observed fatalities in Feb and March. So that is, if I was to take this yellow curve here and shift it by a month, up till the last few days, it does a reasonable job of what's happening currently, except now things are going up. So I think, like I said, I would stop trusting these models for making predictions of levels, etc. Okay, but this is still worth keeping in mind. I think this is something which is there may be something to be said here, because this is suggested by the models. Time to peak in January opening up, and after 3 months, the peak happens. And after 2 months, valley happens on February 1st of fatalities. So 2 months after the valley, you see a peak. This peak comes down if you had this opening up on November 1st because there were more people susceptible. So that's kind of telling you when to expect a peak. So I guess the case I'm trying to make right now is that one can begin to infer from this data and other data that peak in Mumbai should not be very far from now. And that, at least that's being suggested. So let me talk a little bit more about this.
Quick question.
Yes.
Milind is asking on YouTube, what age group is seeing the maximum fatalities right now? Is it still senior citizens?
Oh, yes, of course, and by far. So that's not
it's very similar to last year.
It's very similar to last year, yeah.
Okay.
And that's not going to change, yeah. Yeah, so this is the data one can get from the dashboards that BMC puts out daily. But yeah, this is true. I don't have the precise numbers, but that's not going to change at all. Okay, so this is the case where we do some scenario analysis. So what we can do from this simulator, nonetheless, while we don't quite know what's going on the ground, we don't quite know how many people are infected now in in month of April. We don't know again how many reinfections are happening, how many variants are there, but we can still do scenario analysis. What if this happened? Then what would things look like? I think that is still insightful. So that's what we do. So assume compliance 60%, 40% till November. This is just going back to the past data because we were matching it very well till that time. You assume that it becomes 50% in non-slums and 30% slums in December. Again, we have Google mobility data which suggests that there was opening up. So that can be a guide. But it's only a guide, but it's plausible things. We just want to see if you do plausible things, what happens. In January, 40%, 20%, and thereafter 20% and 10%. So 20% of non-slums are compliant, 10% of slums are compliant from February 1 onwards. So that's what we assume. And we also assume that vaccines are red curve here. So 40% of above 60 are vaccinated exactly on April 1st. And it becomes effective on April 1st. So what we are trying to capture, this is just very approximate modeling, that actually 40% of people in all of month of March were vaccinated, above 60. They would take a few weeks before the vaccine becomes effective. So all of that we are approximating just by saying that, okay, let's say that they became exactly vaccinated on April 1st. And we'll assume that the vaccine is 75% effective. Again, we just want to get a sense of things. We don't, we can't be, I mean, one could be more accurate, but right now it doesn't make sense to nitpick too much. And then you say 40% on May 1st, similarly, and 20% on July 1st. So that's your red curve. And what do we see in this world? And I'm going to assume here that economy was, so I've not said it here, it was 50% open by end of January, and it opened to 65% thereafter. So this much of opening up, about 30% opening up happened at that time. And this was based upon the data we saw, a number of people traveling on buses and trains before February 1 and after February 1. So we saw immediate rise of 30% because of opening up of trains. So that gave us this number. So whenever we can, we try to use these numbers. In practice, it could even be that the opening up is actually more. It's but it's again, we don't really know. So let's stick to this. So what do we see? Again, what you see is that this opening up here, because we've now made people less compliant, it's matching the fatality data. But as per this model, fatalities actually peak around 20. And now we know, okay, this was a really bad model. Because we are never ever projecting it to be a true model. We knew it would be wrong, but now we know that it's actually it can be way off because we've already seen 27 fatalities. It's likely to go much more. But nonetheless, you get some qualitative features from this. So what are the qualitative insights you get? One is you begin to see, as I mentioned earlier, that this red line corresponds to vaccines. So red line begins to separate out from other lines around May 1st thereabouts, a little bit earlier than May. That's when vaccines begin to show a substantial difference in fatalities. And again, because fatalities happens to elderly, so we'll see there. So Pranav is saying now, how do you factor virus mutation model? Also, could you share prediction against actual data? So all these red lines are actual data, right? So we are sharing predictions against actual data. So we are actually matching actual data here. That's a very good question. So these are the actual data here, and all our previous assumptions, they were not made after the fact, most of them. They were made before the fact, and they matched the data. But then, as I mentioned, to match this, we had to use the fact that people are less compliant from December onwards. It just seemed very plausible. So once you plug that in, you seem to be matching it. Okay, now your question was virus mutation. So let me come to that in a moment. Yeah, so antigen testing, no, we've not really done the impact of these things. these are, I mean, the scale at which you really have to do them to have an impact would be massive, would be kind of unrealistic. So we've not done that, but I think that's something from our previous experiments. We know that in a random population, you do need to do a lot of testing to really make an impact to lowering numbers. Okay, right. So the point I want to make here is that even with these models, first of all, vaccines begin to show up towards the end of April, May, thereabouts. They start to show an impact. And then they show a substantial impact. This is something one can still trust around July, June, July. Now, numbers here are increasing because we've assumed that on June 1st, schools open up. So schools open up will lead to, again, another rise in numbers. But what's interesting is that if you have vaccines in place, then this rise will be less, much less, much less noticeable. So that's something to keep in mind. We can't trust these graphs precisely, but something to keep in mind. Other thing to keep in mind is, again, where does a peak happen? The peak in fatalities happens around the first week of May. It's a little bit different in this different classes, but around the first week of May. Now, so suppose it's around the first week of May. Now, if you say that the cases are going to peak about 2-3 weeks before that, that tells you that the cases that we are seeing right now, if this model were to be correct, and it's not correct, would be around mid-April to end April. So that's something to keep in mind, that our numbers are kind of suggesting at least that peak may be a few weeks away in the data, because after a while you run out of people to infect. So that's one point I want to make here. So now, as Pranav was asking, how do you model variants, more infective variants? So we don't know how much they are, etc. So we can only do what-if analysis. So what do we do here? So what we did here was, and let me just talk about this slide. What we did here was we said, okay, suppose 20, so I must have written it here. Hypothetical setting where on February 1, 20% of infected have a new variant. So we look at people who are infected on February 1st, and we assume that 20% of them have a new variant which is twice as infective, equally deadly but twice as infective. Then what will happen? Now, we don't think 20% is an accurate number at all, but it's a what-if analysis. 20% gives a sense of what would it be if it was 5%, and what would it be if it was 50%. So it gives an idea of what to look for, how the numbers will change. So then what you see is this orange curve, basically, right here. So this orange curve is with the variant. This green curve is with the variant and with the vaccines in place. And this blue curve is neither of those things, just a base case. So what you see with orange curve is you see much higher fatalities, peak fatalities. These are now above 30, closer to 40 on some days. And that suggests to you that if the variants were more, you'd see even higher fatalities. Now, we have assumed that the city opened from 50% to 65%. If actually the city had opened much more, again, you'll see much more fatalities. So we don't know these things, no point trying to fit at this stage. But, at least these are suggestive. What else do we take from this graph? And that's the interesting part. Now we have a more effective, virus happening. So infection is spreading faster. Even now, the peak is happening around, in the base case, it's after May, and otherwise it's happening towards May, mid to late April, right? So having more infections, faster infections, is only expediting when the peak happens. Earlier, I mentioned to you, if we had opened up in November, so we had more susceptible population, that would have also expedited when the peak will happen. So all of this is suggesting that, things, if they go bad, then, a lot of people get infected faster and peak actually happens faster. Otherwise, if they don't go so bad, then peak will take will be between, say, mid-April to end April for the cases. Okay, sure, I'll do that, yeah. Right. Okay, so that's the big conclusion from this, that, the peak, if this what-if analysis were to be believed, if more infective variants were there, peak would happen even earlier. If people were more susceptible than we assumed, peak would happen earlier. If people were more infected already, then we would not see the kind of cases that we are seeing. And the only reason peak would be further delayed would be if there, people are kind of over time there are more restrictions at place, people are slowing down their movements, so infection has slowed down, so it happens, goes forward, and peak happens later. So we're not really seeing that kind of behavior. So this is suggestive that one should, that's the only thing we can kind of say from the model right now. Otherwise, given the uncertainties due to variants, due to many other things, our model has no role to play right now. We should just wait and watch and understand the data better until we get more clarity on what the data has. Mathematical modeling is about making the right assumptions. And right now we are not at the stage where we can make right assumptions. But nonetheless, this what-if analysis does suggest that one should be seeing a peak in a reasonable time, 2 to 4 weeks from now. So that's the suggestion that comes out from here. This line is also, yes?
A question on YouTube.
Okay.
Does your model take into account the reinfection rate, given that now ICMR has a study on the reinfection rate?
Right. So it doesn't, suppose you take, as a study says, about 5% reinfection rate. What that would kind of mean is that when we start this opening up here, about 5% more people can be infected because they can be reinfected. So that just means that you have more susceptible people, so to speak, with you on February 1st. So again, from whatever we've discussed, that would suggest that the peak would only expedite the peak. So our broad conclusion still remains true. But otherwise, right now, we're not making predictions or projections about how fatalities will evolve. So in that sense, we've not incorporated reinfections to make those projections. But the conclusion that I'm trying to suggest right now is that the peak may be near. That is not going to be affected by reinfections as per that data. Is that okay? Does that answer your question? So let's move on. Okay, this line is also very interesting. This line tells you that in this hypothetical situation that we have, this is proportion of new variants in the population. So you start with 20%. By April 1st, this proportion grows to about 60%. So when the infections are rising, the new variant takes off at a dramatic pace. So I don't know if this is well understood so far, but this is quite an increase that's going on. I don't know. Does this kind of explain the fact that we are suddenly seeing cases continuing to rise because the variants are going, we're just assuming variants are twice as infected. Maybe they can be more infective. We're just assuming that, they're equally deadly. Maybe they can be more deadly. But the fact is, if they were indeed present, they would spread very fast. And by now, there'll be a lot more in the population. So that's something to be kept in mind. But these are the kind of things which the model suggests. Similar analysis when the cases were coming down in November, September, October, November, December would show that the variants go very slowly. So when the general population is not mixing, there's not much of disease around, even the variants don't grow that fast. But when things start to open up and there's not mixing, that's the time when variants take off. So that's an interesting insight to be kept in mind. Okay, so this is, any questions, any other questions? All right, so this is a more representative vaccination model, just one more what-if analysis. So 75% effective vaccine as before, 45% above 60 vaccinated on April 1st, 15 lakh above 45 vaccinated on May 1st. So we're just approximating the fact that, okay, 15 lakh people will get vaccinated in the month of April. So these are above 45 people, and these include 40% above 60. So we're trying to capture that scenario here, right? And then we say 15 lakh will get vaccinated above 45 on June 1st. So we're saying in the month of May, 15 lakh people who are above 45 will get vaccinated. And then we are saying 20 lakh people at random will get vaccinated on July 1st. It's a reasonable scenario of how things might happen. It's not going to be accurate, but it's not too far off. And then you can see in that case, again, what happens is that, vaccines is this green line now, and this orange line, I guess, is without the vaccine. And this is, again, the new strain. So vaccines make a substantial difference by the time you reach June, July. Again, they begin to make a difference around mid-April, not so much around that time, but they make substantial difference later on. So much so that, maybe hopefully, and this is not at all a projection, but we'll see by that time that they calm things down so much that one can think of opening up schools around that time, hopefully. But it's not a projection. We'll have to wait and see. This is not the time to make projections, but we can still hope. All right. So if there are no questions, now I'll talk about mathematical modeling and Monte Carlo simulation. How do we draw these conclusions?
Okay, so there are a couple of questions. So one on Facebook says that how does the excess mortality compare to previous years? Overall taking all deaths into account, etc. I mean, is there a significant excess mortality in Mumbai due to COVID?
Right. So I think in the last year the mortality was 90,000 people in Mumbai. This was 2019, I guess. I forget now the exact period. Maybe it was still, I'm not sure exactly, but year before this COVID. And in the COVID year, it was 110,000. So about 20,000 excess mortality. Now, of the 20,000 excess mortality, about 12,000 are COVID fatalities that we know. Now, remaining 8,000, we know that because of COVID lockdown, a lot of movement does not happen. So a lot of people who would have received healthcare for other reasons don't get it. So that could also account for something. Underreported death in COVID. There are protocols right now. If somebody dies and has not been tested for COVID, then we don't test it and classify that person as COVID test. So there are a variety of reasons where they may be undercounting. So that could perhaps, those things could explain the gap of 8,000. They're just difficult to kind of assign. And a lot of times it's very difficult to assign kind of person to COVID or non-COVID. Person has all kinds of serious mortalities. So BMC tells us that they feel genuine difficulties in classifying. And as I mentioned, a lot of deaths may be just because people could not get the healthcare that they would have got in normal times. But excess deaths are 20,000 and 12,000 thereabouts are already accounted for through COVID.
Okay. Alak Ray on YouTube asks whether your modeling assumes that the vaccines are equally effective against mutant variants. And if the vaccine is not effective against the variants, how does that affect your results?
Yeah. So right now we are just making simple assumptions. So we assume they're equally effective. If they were not effective against a variant, then the numbers will blow up. Then you're looking more at this orange curve here.
Amol has a follow-up question. I mean, more infectious is not necessarily more deadly, right? So the variants might just be more infectious, but not deadly. We don't know if the variants are more infectious or more deadly. I mean, we know they're more infectious, but we don't know if they're more deadly or not. Is that the correct statement?
Absolutely correct. And that's how we are modeling it for now. We are assuming it's twice as infective and equally deadly.
Okay.
For lack of better information, just to,
And a quick one from Deepika was asked, which other cities in India would you say could possibly show a similar trend?
I think in Maharashtra, the other cities, Thane district and Pune district are certainly showing very similar trends. And others are smaller cities, but their trends as we saw early on are not very different. But certainly Thane district and Pune district are not too far from how Mumbai is behaving. So what in that sense, one says that, okay, whatever we are seeing in Mumbai has an analogy in these cities as well.
Okay, and there's a question asking, what about cities like Kolkata, which have an election, etc.?
Yeah, I'm not following the data on that. We saw earlier that in West Bengal, numbers are rising now. So we'll see. I mean, what's interesting is that, I don't know if you see people jogging on Marine Drive. I certainly do on Sundays. There are thousands of people and nobody wears masks, but then we're running outdoors. And I've not heard of any case coming from there, just anecdotally. It's anyway, let me not talk too much about that. But the point is outdoors infections is less. So that is perhaps a mitigating factor. But people come very close for a long period of time. So all kinds of things can happen. So it's scary. One just has to wait and watch.
Okay, I think we should go ahead. It's already about 12:05.
Sure. Yeah. So. Okay. So mathematical. So by doing epidemic modeling and simulation, primary goal is to assist policymakers and epidemiologists in making informed decisions in difficult circumstances. And then, like right now, should we go in for a lockdown or not? Unfortunately, I think it's very tough to draw too many conclusions. We don't have a good mathematical model right now. Let me not talk more about this for a moment in the interest of time, but let me just motivate mathematical model. And this is more for the students in the audience. So what are we trying to do? We're answering a question when we build a mathematical model, right? So let's take one example just to concretize things. So suppose you want to find the large weight probability in the vaccination queue. You go to, say, Bombay Hospital or JJ Hospital, there's a large queue. Maybe the manager of that facility is wants to control the chance that people wait more than half an hour or 1 hour, because that can again propagate the disease. So it's an important performance measure. Okay, so you spell out the inputs that are going to determine the output of interest. Output is clear now. That's what we want. What our goal in this is, what we want to measure, that's clear. What are the inputs that are going to affect that goal? So that's what you do in a mathematical model. So then you quickly find out, as you think about it, that the inter-arrival times, how people are coming in and how long they take to get served, and what kind of queue you have. So suppose you have a single server queue. These are the important structural things that are going to determine the waiting time in the queue, right? So you want to make assumptions about these things. So in any model, you want to make very specific assumptions about the reality, right? And then you have to specify the rules that translate the inputs to outputs. So the rules are also assumptions, basically, right? So what are the right assumptions to make that convert the input to output? Now, what do you have to do in this? You keep it simple. When you're dealing with people, I mean, this is not physical systems. You're dealing with people and you're dealing with viruses, and they behave in an unpredictable way. So you can't, there's no point make terribly complicated assumptions as such if they don't, if there's bigger uncertainty, there's a bigger elephant in the room of uncertainty already around that you can't handle. So there are trade-offs here. You make realistic versus tractable assumptions, right? You want to capture the really important things that affect the output in a realistic system. So you want to capture that through the assumptions. At the same time, you want to keep things simple so that you get results which are nice, and also you can you get insights into what's driving the result. Often insights are much more important. But bigger point is assumptions determine the quality of the results. Wrong assumptions, wrong results. That's why we are extremely wary right now to make any forecast. I think about a couple of months ago, I was actually playing with fatality data. It seemed like we were matching well. And I was kind of thinking that, okay, maybe we have a forecast and all that. But, that fatality data match went away very quickly. So, but over time, you also realize that there's so much uncertainty that mathematical modeling in this stage is perhaps not a good idea at all. But let's come to our queuing setup. In queuing setup, you realize, okay, this is the queue. Suppose this person's in the queue and they're going to be served for 10 minutes, getting a needle from the doctor. The inter-arrival time, let's say, is 9 minutes between this and this customer. I'm going to call them customers. And this customer is going to take 8 minutes. You measure it and find out when the customer was actually in service, how much time the customer took. The next customer came after 5 minutes and that person took 9 minutes of service time, so on and so forth. You know that if you have all of this data, then you know what the waiting times in the system are. So now we are ready to make a mathematical model. One model can be that the inter-arrival times are independent and they come from some probability distribution. So you know what probability distributions are. That's the way we model uncertainty. We can't say for sure when the next thing will happen, but we can say that, okay, it's completely unpredictable. But if we see lots of these things, then okay, maybe 20% of them will be between 10 minutes and 5 minutes and so on and so forth. So this frequency distribution we can come up with. So that's what probability distributions do for us. So we'll assume that for inter-arrival times, to the extent that's a good assumption, okay, we'll get good results. To the extent it's a bad assumption, we'll get bad results. So for service times, we'll also assume that they're independent. Independent means that if I tell you that one person's service time was 6 minutes, that in no way helps you predict the other person's service time who came after this person. Now, you could say that if this person took a long time, okay, maybe the server was in a bad mood or something was going on. The other person will also take a long time. So you have to ask yourself that, do you want to build these kind of complexities, or do they just kind of obfuscate, confuse the issues? Okay, and then the service rule is first come, first serve. Now, again, is that really true, or there's some people who are getting priority over the others? So you have to ask yourself these things, but let's start with this for now. So these are assumptions that, for example, one makes in a mathematical model. So in our simulation model, we make a lot more assumptions about the system. So you have to be worried about each assumption can be wrong, and what does that mean? Okay, so now what do we do? What would a mathematician do? They will solve the model. So they'll say, okay, A1, A2, these are inter-arrival times. S1, S2 denote the service times. So there should be service times here, right? Now, since we have a first come, first serve in the rule in the system, we deduce, this is the logic of it, that the waiting time of n plus first customer will just be the waiting time of nth customer plus service time of the nth customer minus the inter-arrival time between the nth customer and the n plus first customer, right? That's your waiting time. My waiting time, person before me, their service time minus the inter-arrival time between us. Of course, if the inter-arrival time was so large that I came to an empty queue, then it'll be 0. So you make such a, this is just the logic of the system. So you build up these logical relationships. And now if you're clever, so for example, I have mathematician friends who are really smart, and I know that because they keep telling me that they're really smart. Then you can recurse on this. You have this relationship. You can say, okay, Wn plus 1 satisfies this, but so does Wn. So you build up kind of a relationship, and then you play with that. And if you do clever things, you can begin to say something about what's the chance that the waiting time of a customer, maybe after a long, if you look at the customer after a large number of queue has run for a long time, greater than 30 minutes. So you can develop approximations for these things. So that's how mathematicians typically work. You make a underlying assumption of the model of the reality. Once those assumptions are made, then through deductions, through clever kind of relationship that exist, you draw conclusions, and then you come up with theorems. And these theorems are usually easy to come up with when things are simple. When things get complicated, and inevitably sometimes things have to get complicated, then you're in trouble. Then mathematics per se doesn't help you that much. This is only simple for feasible for simple models. But the other option you have is to run the model. That is, use Monte Carlo simulation. So most of you would be familiar with this, but let me just say this for people who are not. What you can do then is you can use the computer to generate samples of inter-arrival and service times. So inter-arrival times A1, A2, and so on. I know their probability distribution. I've already built a mathematical model. So mathematical model is already there. That has been set. But now, rather than using logic to draw conclusions, I'll just use my computer to generate inter-arrival times. So data is being generated by the computers. And there are very elegant ways of doing this. Lots of research goes into this, but this talk is not about that. This is a method which was arrived at by Stanislaw Ulam, who's a mathematician and nuclear physicist, and John von Neumann, who is John von Neumann. So this was during the Manhattan Project. Again, a long history. But nonetheless, computers can generate these samples for you very quickly. And then you simply do the calculations from this recursion relationship that you have. So you compute the waiting time of the first person, second person, third person. They do this maybe 1,000 times or something. Take their average, find out what fraction of these guys actually had waited more than 30 minutes. That fraction becomes X1. Now your computer has this nice property that allows you to do this all over again many, many times and completely independently. So now you generate X1, but you also generate independent X2 and X3. So it's like computer, simulate the reality where you were there on the queue, you saw people coming in, getting served, how much they waited, and you saw this many, many days independently. So now you have all this statistical data, you can do statistical analysis on that data and draw conclusions. So that's what simulation does, and that's what we do with the agent-based simulation. All right, so what's the statistical analysis that we do with generated data? So law of large numbers says that, okay, if I take this X1, X2, Xm that I've generated and take their average, that will converge to the correct fraction. Probability the waiting time is greater than 30 minutes. So that means if I use my computer and generate enough samples, I get a pretty good approximation to this. And how good is this approximation? That in statistics people would know is captured by central limit theorem, which says that the sample average that I see looks like the true value which I'm trying to estimate times an error term. The error term has a Gaussian term in it, N01, which just means that all these averages begin to look like Gaussian distributed, no matter what distribution each xi has. And these error terms actually become smaller and smaller the more readings you have. And the sigma is just a standard deviation. So because of these things, you can construct confidence intervals. So you don't get a point, you don't get exact value of the quantity of interest, but you get a confidence interval around it. That's what we do with agent-based simulation models as well. This is just an illustration that suppose my X1 was a probability distribution, which is very far from normal. It's this exponentially distributed random variable. So this is a probability distribution of one random variable. Now, if I take 3 random variables and take their average, what happens to this probability distribution? This begins to look like this. If I take, let's say 30 of these, then I get something which looks very much like a normal distribution. Sorry, I'm just going to ruin it. That looks very much like a normal distribution. So 2 things you see that, okay, the distribution is becoming more and more normal as I take more and more samples. Whatever distribution I start with, this is going to be true. And then other thing you see is that as I take more samples, the peak is rising. So my confidence intervals are becoming smaller. My certainty about the estimator is increasing. I have a much better idea what alpha is. So with these tools, you're kind of ready to do the, you have the estimates. Now, in real, our agent-based simulators are much more complicated. We don't just have one performance measure that's coming out. We have all these charts of number of fatalities on different days, number of hospitalizations on different days, number of people infected and all that on different days. So all of those one can kind of analyze using these ideas, these basic simple ideas from statistics. All right, so broad outline for the remaining talk. So Arnab, when do you want? How long can I go on?
So I think by 12:30 or something we should plan. You have another 15 minutes definitely, and we should keep some time for questions. So I don't know. People will eventually start probably dropping off if we make it very technical, and I'm sure people are wanting to ask questions. So
okay,
yeah.
So then two things. First, I'll talk really, really fast, so I cover everything. So I'll stop dropping some material. And second thing, if I see that nobody's present, then I'll stop talking, I guess. So those are the two rules. But what that means is that please feel free to leave if you need to. Of course, that but nonetheless. All right. So there's some type of epidemiological models. So susceptible, infective, recovered or removed, susceptible, exposed, infective and recovered, and so on. So these are more analytical models. These are more, you solve these models basically. They have a few parameters, things are simple, parameters are easy to explain, but they don't model the complexity, the detail that one needs to model disease spread. But agent-based simulation models can capture the disease spread much better. So in the interest of time, I'm going to not talk about this, and I'll just talk about agent-based simulation model, and I'll talk about details of our model, some of the details of our model that we have, just to give you a flavor of what goes on behind the hood in the numbers that we come up with.
And we've already had a few chai on SIER and things like this.
Okay, wonderful, good. So then I'll ignore that. Yeah, very good. And then if we have time, we'll stop for questions and all. But if people are interested, I'll tell you how to simulate a 13 million city using a 500,000 agent model. And the answer is it's not trivial, but it's clever, but it's very simple. So I'll talk about that, because you have to understand the underlying probabilistic structure better. But let me put this towards the end. If people are interested, for them I can tell you about this. But this is the research with my students Shubhada Agarwal and with Daksh Mittal. All right, so let me move on from SIR models. So I'll ignore this discussion completely. Okay, the point was that the cities, so SIR models are simple models, but cities like Mumbai are very complicated. So this is where people are staying in Mumbai, and this is where they go to work. So, they're working in this place, but they're not living here. They're working here, but they're kind of living elsewhere. So it's very geographically distributed. There's a lot of travel happening. So you have to capture that when you model the spread of the disease. There's a lot of kind of, heterogeneity in the population. Population living in tall buildings are probably much better separated than population living in the slums. So all of that has to be captured. And these are very difficult to capture from simpler models that I indicated earlier. All right. So it's a more detailed, exact model. You model the reality more exactly. Your assumptions are closer to reality, but you determine things approximately, because simulation is time consuming. You don't get elegant solution forms that you get in SIR kind of models. And it's noisy also. So you have to know statistics to do things right. So that's the trade-off. But agent-based simulation models, let me ignore this discussion as well. Basically, what do we do in our simulator? We add population information. So all that information that we have from census for Mumbai, age differentiation, how many people in which age group that we enter, as per the ward. So, different wards will have different population. Slums, non-slums will have different population. Geographic information about where people live, where they go to work, all of that is entered. And then we are going to have, schools and workplaces, they'll be actually modeled as well. And attempt would be to be realistic from the data that's available to us. And then people will be assigned to schools in a realistic manner, assigned to workplaces in a realistic manner. They'll be part of their communities, and then engagement will happen. People will meet, and when infected people meet susceptible people, the disease will transmit with some probability. So that's the idea. So we'll run the system basically. So again, just to outline, we'll generate a synthetic city. So demographics, employment, geospatial data for each ward, high density regions, low density regions, all of them are specified. Age, household, workplace, and school size distributions, as I mentioned. Origin, destination matrices for commute patterns. So all of that becomes the input to create the synthetic city. So we are creating a city of 13 million people in the computer with all the details which kind of match the actual city of Mumbai and details of public transport usage. Very difficult to measure because we never really had a data on how infection is being propagating in the trains, etc. So then we make some assumptions, then you worry, are we making the right assumptions or can we mess up? And we don't really have a great way of checking these things. And then you also have disease progression details. So I'll talk about this in a moment, but the point is what happens is it's not just that a susceptible person becomes infected. They actually become exposed for about 4 or 5 days, again, randomly distributed. And then they may become, they may become infective and they may be asymptomatic or they may be symptomatic for some time period. And if they're symptomatic for a few days, again, that's random, it's different for different people. Then some people will go to the hospital and that will be age dependent. And then again, as I mentioned earlier, if in hospital, some fraction will become critical and that again is age dependent, so on and so forth. So all those disease progression details have to be entered in the model. These are the inputs that we enter to the model, right? Age-based transition probabilities between various states, as I mentioned. Build dynamic to mimic interaction in various common spaces, homes, workplaces, school, community. So once we've entered all these information, we'll figure out what's the right time to when the infection started in Mumbai. Say it's mid-February thereabouts. We'll seed the city with 100 people at the right places who are infected. And now we'll have interactions amongst the population. People will meet at homes, in schools, in workplaces, in communities. And as they meet, there'll be coins flipped to see, to realistically kind of model the infection spread. Now, if you implement social distancing, then people will be socially distant. These coins will have smaller probabilities of transmitting. If people are wearing masks, then again, that will reduce the probability of disease transmitting. If people are not allowed to move that much, then there's not much movement happening because of lockdown. Then also you'll see decrease in numbers. So that's, it's a very detailed model. If you get the underlying assumptions kind of right, the predictions are likely to be quite good. Of course, how do you get so many parameters accurately modeled? That's an issue. So initially, a synthetic city is created of 12.8 million people. Let me avoid all the details now. But I mean, the point, I guess, here is that, okay, you start to see this city with infected people, and then at each step, people meet, they interact, and you flip coins and you decide who gets infected. Then people who are infected follow their disease progression details. And in that, whenever they become infected, they infect other people, and so on and so forth. And we collect statistics as we go down. And once we have all the statistics of the population over time, now we are running for 1.5 years. So then we can plot over that 1.5 years what happened in that city. And we can choose our parameters. So at least early on, we are matching what actually happened in the city. That's how modeling works.
Sandeep, a question. What is the duration of one time step for this agent-based model? I think Philip Cherian is asking that.
I mean, it's of course up to you, but we've been using 1/4 of a day, 6 hours.
Okay.
All right. Okay. So pros are, okay, you can have targeted inventions. So lockdown, social distancing, case isolation, home quarantine, wearing masks, containment zones. When hospitalizations are rising, BMC does this very effective job of kind of containing that area. So movement of people around that area stops. The people are likely to be infected. If you stop their movement, you prevent the disease from spreading. You can have partial and cyclic attendance strategies, protecting the vulnerable, etc. So all of these things can be modeled. And you can compare strategies. It may be difficult to predict numbers, but comparisons, because they're facing the same errors, presumably the difference is telling you still useful information. Okay, so I'll talk some more details about our agent-based city simulator. It's inspired by Imperial College effort, as I mentioned earlier, but we put in many, many new features to capture unique features to India. Okay, this is just all the data that we entered, some of the data, wards, population, slum population, area of the wards, age distribution of people, household sizes, school sizes, workplace sizes, all of that was entered. This is a disease progression that if you've not seen before, it's worth kind of seeing. This is from the Wuhan data again. In person, when they get infected, they remain exposed for about, on an average, 4.58 days with some randomness around it. For about half a day, then they are infective, whether they're symptomatic or asymptomatic. On average, they're infective for about half a day. If they turn out to be symptomatic, and in our model, we assume that that's true in 40% of cases. This seems to match the early data well, so that's why we chose this number. Then symptomatic people will remain infective for another 5 days on average. Again, that can be random. If you're asymptomatic, 60% probability you were infected for half a day, now you recover. If you go to hospital, you stay in the hospital for 8 days. Now in Mumbai, I think the numbers are actually much higher. It's much more than 8 days. And if you're hospitalized and you become critical, you stay critical for 8 days. Again, in Mumbai, this number should be much higher. So we have a question here. All right. Okay, let's take some, and then, so I'll just wrap up in a minute, I guess. And then you have all these probabilities which say that, okay, if you're in this age group, what's the chance that if you're symptomatic, you get hospitalized? If you're hospitalized, you become critical. If you're critical, you die off. You don't make it, sorry. All right, let me just stop here for a moment and take questions. I think we can have maybe questions for 10, 15 minutes. And if people are interested, then I can give more details.
Okay, so yeah, so let's see. So we did the time step model. Now, when you make these, question from YouTube, when you make these very complex models with a synthetic city and so many parameters, how do you validate the parameters? And with so many degrees of freedom, you can pretty much fit anything.
Right. That was, I guess, the comment early on.
And is there, so there are also, is there any effort to, from K. Subramanian, is collect community level data, cohort surveys of households for infections, mobility, work resumption, household expenditure, accessing medical certificates, services, etc., which are typical surveys done by social scientists. Do we have some inputs from such things in your model?
Right. Yeah, so first point, okay, this is von Neumann's quote, with 4 parameters, I can fit an elephant, and with 5, I can make him bigger trunk. So yeah, lots of parameters give lots of uncertainty. How do you validate those parameters? So the more important parameters, which is the transmission rates, how do disease transmit in homes, in workplaces, in schools, in communities, that we choose to match the, when we saw the infection increase in India and Mumbai early on, when no restrictions were in place. So we choose these parameters to exactly match that rate. So that goes a long way. Then the other things which are important are, okay, how compliant is the population? 40%, 60%. That we saw the trends thereafter. And we looked at these numbers and we tried to see what numbers match. We also had data from Google Mobility, which kind of, supported some of our conclusions. So that's how we did this. And thereafter, if the numbers were matching, we kind of thought, okay, it looks reasonable. All the other numbers, home quarantine, social distancing, etc., we took from, and effect of mask. So there's literature which suggests that wearing a mask, if I wear a mask, I'm saving myself 20% of time. If you're also wearing a mask, then probability of infecting each other reduces to 60% thereabouts. So those are the kind of features we built in because we read that in the scientific literature. There are some things. Okay, when you home quarantine, how long should it be? That's a policy, so we just input those parameters. And some parameters we just apply common sense, and as long as it's kind of clear to us that these are not very important problems. If you apply common sense, even if you're slightly wrong, it's not going to change things very much. And if it looks like you're predicting well, you don't worry too much about those details. They seem to be matching what's realistic. Now about how, so we were involved in the Sero survey in Mumbai. So there we got to know, okay, what the level of infection was in different wards that we surveyed, and we got to know what the size of the population was. That was very important input for us. We also got to actually know how many people were using common facilities like toilets and how many were not. Those seem like details which were not so important to be modeled here. So we didn't include those modeling here. But as to your broader question, I would like to see far more research on what's going on in all of India and certainly in cities like Mumbai at the ground level. I think, for example, if there's going to be a lockdown, there'll be enormous amount of pain in the city. Do we have data which quantifies that, gives us a sense of it? I don't think we see good enough data of that regard. So it's a very much needed thing. Many more social scientists should be doing some of these things. Any
Okay,
other
and yes, I mean this. Do you sort of use coin flips to decide this randomized thing of who is infected and who is not, or is there a better way of simulating where the infections are and something like this? I mean.
No, I mean, the way to think about this is, the probability of the coins are determined by where the infections are. So in a more infectious area, two people, when they meet, if one person is more infectious than the other, then the chance of one person infecting the other becomes higher, 75%. So the bias of the coin captures this heterogeneity that you're kind of alluding to. But it's still reasonable to assume that there's some randomness. That's more perhaps a better way to model things than to assume that if they meet for certainty, things will happen.
Okay, now maybe a more we're heading to 12:30. A more question, which I don't know what your take is going to be. Based on all this, what do you think are the recommendations that you have for the immediate future that a city or a state or whatever government should can take out of such a model?
Right. Right. I mean, right now, as I've been saying, there's so much of uncertainty that we don't really trust our model to make good projections until we figure some of these uncertainties out, until collectively we figure all these uncertainties. Now, what our model is suggesting, and that's something to be kept in mind, that in the next 2 to 4 weeks, you may see a peak, but these 2 to 4 weeks will be very painful. And we are already seeing right now that, ICUs are filling up, very little spaces left. Oxygen beds are also becoming short supply. So it's not our decision to make or even our recommendation to make, because our analysis doesn't help beyond what I've already said. But the government will have to look at, because what does some kind of lockdowns buy you? They buy you time to again build up your medical capacity, and they, people will, if there's a slowdown in movement, then medical capacity will free up, which will then help people who are getting infected. So they'll have to keep this, they'll have to make a decision between, given the constraints that they have, how severe those constraints are, vis-a-vis if they put the economic cost on the population, how severe is that going to be? And how will the population react? Nowadays population is taken a view that, they don't want to be kind of put in lockdown again. So these are issues for the government to take into mind. All we can say right now is keep in mind, it's suggested that, okay, in a few weeks, things will peak. So, that's a hopeful thing to keep in mind. From the policy point of view, I don't know if it changes very much, except that, okay, you start something and then a few weeks later, you actually begin to see, are we actually seeing the kind of decrease? And once we start seeing the decrease, then we act accordingly. I don't know, it's not a great answer, but I don't have a great answer.
All right. So a question about your model is, can the model be used to generate disaggregated insights for different groups of individuals based on their demographics or age or social interactions?
I think, yeah, that's correct. So one can do that. One can. So certainly we can see in different age groups what's going on, how much infection is happening, etc. That also kind of is a way to kind of correct the model. If our model is saying more younger people should be getting infected, while in the reality more older people are getting infected, then we can correct our model to take this fact into account that we are mismatching. Okay. You can put in geographical details and say, okay, this region will see the growth of disease first, and so on. Those things can happen.
Okay, and what about things like, people is wondering what goes into your model? Do comorbidities, false positive rates of tests? Do you take into account all these things?
So what's the other point after comorbidities?
False positive tests.
Okay, yeah. So these things we can take into account. Comorbidities, we just didn't get around to the effort. It was, it was just something that we did not do, but it could be done. It should have been done, actually. It's important to do that. We just didn't do that. False positive rates are very easy to incorporate. We haven't done that, but they're very easy to incorporate.
Okay. And probably a very vital thing is, what is the typical running time for a 10 million kind of city with 6-hour updates? Are you using a supercomputer? I mean, how are you doing this thing?
Yeah. So we are using high performance computing in TIFR. Earlier, when we were running 4 months, it could be done in about 2 hours with all the new bells and whistles we put in. Now we run it for 1.5 years. So it goes on, it goes on for 6-7 hours for one run. And then we do many runs. So if we may do 5-6 runs and take their average. So these are runs done in parallel. Now I'll show you, if those of you are interested, on how we can reduce dramatically by a factor of 10 to 20 times. So that will come to later, and still get pretty much the same results.
Okay. So yeah, I guess what we can do now is sort of, we're probably going to get a little bit more technical in the next 10 minutes or so. So if you want to show something, maybe you can. Okay. And after that, we will probably wrap up, and people can, sort of ask us questions or something later on if they'd like, because we are seeing the audience sort of drop off on various places. So yeah, go ahead.
Sure. So yeah, this was just the kind of sample of results that our model currently outputs. So this is how the infection is spreading over time. So the left-hand side is daily infection. And you can see it's very jagged, because as you change a policy, it immediately has an effect on how infections are happening in the city. So it captures that sensitivity, which is realistic. And the right-hand side is capturing, cumulative numbers. I won't go into the details. This I've already shown to you, that one can disaggregate between slums and non-slums, how infection is happening there. One can do much more. This is up to us. This was our attempt to match hospital numbers and critical beds, etc. This is when we had some more information about how many people were coming from outside into the city, etc. So that helped us match these things. It was not a terrible match, but now since we are lacking a lot of information, we didn't attempt it this time. We're not kind of focusing on these numbers. Fatalities we've already discussed. Okay, so now I'll come to the technical part. So key drawback is, can a smaller city with same homeschool and workplace structure give us the correct answers? So as I mentioned, this is joint work with my students. So let me tell you what's a naive thing to do. The naive thing can be that, let us, instead of running a 12.8 million city, let's create a 1 million city, same household structure, same school workplace structure, smaller communities, and let's see what numbers we get from that community. And maybe we scale them up by a factor of 12.8, right? So just if we see infections in a 1 million city, scale them up by 12.8, that gives you infections for a 12.8 million city. If you see fatalities, you do the same thing, so on and so forth. So it's not such a bad idea as you would think that this is so naive, it should be bad. It's not a terrible idea. You see in this picture here, this is the no intervention setting. The orange is the scale model, and the blue is the unscaled, the bigger model. And you can see that they are actually exactly matching in the beginning. Later, they separate out. So what happens is, initially, and this is interesting, you start with, say, 100 people. It makes sense to start these models with small number of infections. That's kind of a realistic capturing of what happens in the city. And then, 100 people, whether it's in a big city or in a small city. So this is just a general scientific insight. They are going to evolve their family trees basically similarly. It's very interesting. As per our parameters, 70% of them will have no children whatsoever. They will not pass on infection at all. And only 5-10% of them will lead to a massive tree that grows. So we actually see that. So these trees are going to grow independently of each other, basically, whether it's a small city or a big city. That's why, you see similar numbers here. And when you scale, in a smaller city, I have 10 people. In a bigger city, I have 128 people. You scale it, you get similar numbers. 10 people is more noisy, but you get similar numbers. Things go wrong here, because as infections grow, you're hitting the houses which may be uninfected. And maybe as, in a 1 million city, fewer susceptible people are being hit by many multiplicated people. They're trying to get you infected. While in a bigger city, these people are infecting a lot more people. So there you see more numbers vis-a-vis here, because a lot of double hits are happening. So, in relative sense. So in that sense, you see that your approximations go bad in this setting. And they go really bad when you have interventions. So all of this goes completely haywire when you have interventions. So that's one insight. But this is interesting here. This graph is telling you, suppose now I start my city. I start my 12.8 million people city with 1,280 people infected. And I start my 1 million city with 100 people infected. Right? Now when I observe them, I get exactly identical curve. Well, with slight kind of problem in the top, but much better match than before, because I have larger number of people that I've started both the cities with. And what's interesting that's going on is, because there are larger number of people, there's a lot more infection that's going on. And it's essentially following a deterministic behavior. It's like in the SIR model, you're following the fluid limit, so to speak. So both of them are following a fluid limit. So bigger city, which is 12.8 times bigger, will show 12.8 times larger numbers. And you actually see that more or less right through. And this effect becomes more pronounced when you start the city with 1,000 people in a 1 million city and 12,800 people in 12.8 million city. Then there's a completely exact match. So that tells you essentially what goes on in these models is, and with all generality, with all the bells and whistles we have in place, whether it's lockdowns, opening up, variable compliance, with all of that. Initially, the cities are starting independently, whether you are a 1 million city or 10 million city, it's exactly going to be the same thing. Once you reach the fluid limit, then the determinism process starts, the initial state of that is going to be variable, but once the evolution starts, it's going to be deterministic. And there, once bigger city is just going to grow at that much more. There's just be a scaling involved between the two. So you multiply the numbers of 1 with 12.8, and you get the numbers for the bigger city. So that's the underlying structure. That's how things happen. Not just in our simulation. Very likely, that's how things happen also in very similar cities. Just that you don't have cities which are that similar. All right. So what more can one say? Now, if I look at two models, this is again 1 million city and 12.8 million city, and I see how the disease is progressing, you see that for about 30-35 days, they are actually, more or less progressing similarly. Even with the stochasticity in the initial period, for 35 days, because these are independent trees evolving, the size of the city is not really playing a role. And you also see, as we saw earlier, after about 5-6 days, about 7-8 days, you have enough infections in the city that the city becomes deterministic in its behavior. So what that means is that in this time period here, you are evolving, 1 million cities evolving exactly like 12.8 million city. But if you were to scale up your numbers by 12.8, then you're evolving like a 12.8 million city with 12.8 million number of more people. So both these things are happening in this region. That's very nice. And what does this tell you? So let me ignore the math here. I think it's too late for that, but one can develop nice asymptotic regime to kind of prove theorems to make this very concrete. Exactly what phase transition happens, what behavior happens at what stage. All of that can be made very concrete. But let me just tell you the big picture what we can do. So I'm ignoring all these stuff here. The big picture is as follows. What should you do? In the simplest setting, what you should do is as follows. Run your small city model, 1 million model, till say about 35 days. Our aim right now is this. Our aim is that we want to run a 1 million model and get answers for the 12.8 million city. So I'll run it like this. And now I know that at this point, both the cities are together. But I also know at this point, if I multiply everything by 12.8 million, I get a bigger city's numbers with the 12.8 times more population. So I get that as well. So what I do instead is, because both the cities have these numbers, I go back and find a point that I have the same number of infections that I have here. So I shift basically. I shift back and I find the point where I had 12.8 times less infection than I have at this point. Then I take this curve here and put it right here, plug it right here, and I get this whole curve there. So that's how these two things match basically. So that's just shift and scale. So I take this curve from here, plug it in here, and whatever numbers I'm getting, I'm going to scale by 12.8, and I exactly match my bigger city. So shift and scale. Now this goes wrong. So this is one more idea is needed when interventions are present. So I go to say day 35 here, and I know that, for example, home quarantine is started on the 40th day. So now when I say, okay, I have these many infections, let me find the time in my city when I had these many infections. Because and one can prove that the distribution between these two is same. This is being technical now. But in any case, the point is these two are very similar in some sense. So I'll bring this configuration here. But the point is, at this point, I'm going to see a lockdown in 5 days. But here, I don't see a lockdown in 5 days. So I restart my city at this point. And whatever I get, I restart my city so that after 5 days, I'll have a lockdown. And that is the path I attach to this. And with that, I get the complete model. So with this shift and restart and then scaling, I get an exact match to my city. So that's what you see. You get a perfectly exact match with these simple 3 steps. Shift, restart, and scaling. Okay, and this is just showing that the same thing can be done in a more complicated setting. Let me stop here.
So can we take a few questions? One is, are these slides of yours publicly distributable, and can you put them up on your website? And also, can you tell us you said the October thing was published somewhere on your website or something?
Sure.
So we'll put them up. We will put them up on our page and on the. We can put it in the comments, I guess, on YouTube if you have it. I mean, if you have the site, we can just put it in the chat.
Sure.
Okay. A couple of questions are since these are on questions on models, I'm taking them. Is agent-based modeling always better than variants of SEIR, or in higher dimensional epidemiological models that take into account more variables?
Yeah.
And is there value to developing such models, not for COVID, but maybe for other disasters and something else? I mean, at things like this.
Right. I think it's healthy to have all kinds of models in all kinds of groups. That's a broad picture. So it's not good to say one model is better than the other. But the SIR type models are, the parameters are estimated better. So they're more robust in some sense, and they give you much better macro level answers with more reliability. You worry less about uncertainty around them. They can't capture all the heterogeneity. So in that sense, they break up. So one worries about that. How accurate are they? Because there's so much of heterogeneity that's not being captured. And once you start bringing in heterogeneity, the computational cumbersomeness becomes massive there, much more than with the simulation models. Simulation models, I mean, all of it also depends upon who's doing the modeling, how well they understand the underlying assumptions and the dynamics of it. So I guess in some sense, in all of these things, you also have to kind of hope that the people who are modeling these things are doing a very good job. I guess the drawback of agent-based simulation model as such is that there are a lot of parameters to be estimated. So if the underlying parameters are well estimated, then I would think that they'll also perform quite well. So the answer is, I think both the things are, probably very good and are desirable. And to your other question about are these beyond the COVID, so all of these are certainly relevant to epidemiology in general. So you can modify this and model HIV progress or influenza virus progress. So these would make perfect sense there. And certainly these ideas which I showed you right now of kind of shift, restart, and scale would also be helpful there, because it's very important in this world. One reason agent-based simulation models are not done, as Gautam Menon was implying, is that they take a tremendous amount of time. But now what we are saying is you have 500,000 population. So whatever I showed you for 1 million is also true for 500,000. And no matter how big your true city is, can be 13 million, can be 130 million, you still get very good results. So in that sense, these are, so it's promising to do more research on these things.
Okay. Is there a metric to say how good a model is? I mean, can you compare, like, if you have two models, this predicted X and this predicted Y, is there like a thing looking at the variance and how accurate it was or something? Is there a metric to test how good a model is?
Right. I mean, big picture, of course, is the quality of the pudding is in the taste. So the metric is going to be how well your projections are, if that's what you're going to do. But your point is, have we come up with the right specific metric to say, okay, this is what actually happened, this is what we predicted, let's look at the square of the error, let's take the average and predict that as a log square error from this model vis-a-vis log square error for some other model. One can do these things. I think we're not at that stage yet. And, in some sense, the objective of all of these models is to give qualitative guidelines. So any metric will have to kind of say, okay, this is what really happened qualitatively. And did your model get it right, or did you fail dramatically? That would perhaps be a more realistic, accurate way of evaluating models than something.
Okay. How many runs do you average over to create these graphs? Also, since some of these runs might stochastically cause the infection to die out very quickly, are all the runs taken into account in the averaging process, or only those runs that cross some threshold of infected individuals?
No, excellent question.
Philip Cherian Tashoka, I think.
So
yeah, go ahead.
So the point is, these are large models. So typically when we run a 12.8 million city model, so there's a lot of kind of noise that's already getting canceled out, particularly when you get to the middle of the statistics. Maybe early on, it may be a little bit noisy, but we're not worried about them. So 5 runs, and because each run takes long, so you see these kind of shaded regions that I have around these lines. These are confidence intervals. So with 5 runs, you're getting fairly good confidence intervals. So in that sense, we just take 5 runs and that works quite well. We're not worried about statistical noise, at least in this. Now we are starting these models with 100 infections. I mentioned to you that each infection has about 5-10% of probability of taking off and leading to a huge tree, 75% probability of not having a single child, and the remaining probability of having few children. But if there are 100 of them, then that issue of everybody dying off goes away. So overall population will evolve in each run, and it doesn't look that noisy. So 5 runs by and large we are quite comfortable. We don't get that much of statistical noise.
Okay, great. I think with that, it's getting to almost 1 o'clock. I think we should start wrapping up. I'd just like to thank you, Sandeep, for taking your time on a Sunday morning and telling us, and not just what the results of the model say, but taking us into the heart of the model, under the hood, telling us what's happening and what are the parameters that go into such a complex thing. And I'm sure there are going to be lots of questions. You can always email us, outreach@tifr.res.in. We will try and take them and at least get them to Sandeep. And Sandeep, you will put up the things on your webpage, or give us, we'll put up the links to that as well. Just to tell you that we will meet again 2 weeks from now. Hopefully things will be past their peak or at their peak, whatever, but Chai and I will go on. We will have a session not on COVID, but we will be doing a live from the lab session at TIFR, where you will visit one of our many exciting research labs over here. So with that, let me thank all of you. And as after listening to this, you certainly know that trust the models, but still wear a mask, get vaccinated if you can, and please take all the precautions. We are going through a rather crazy time in this pandemic right here, and it's all of our responsibilities to make sure that we don't contribute to careless behavior that actually spreads it further. So please be careful, stay safe, have a nice Sunday. See you later. Thanks for watching Chai and Y. Join us on another session. Thanks, Sandeep. Thanks again.
Thank you. Thank you, everyone.
Sandeep, can you end the live stream?
Right. Oh yeah, let me add one of the screens at least.
I cannot end the meeting. Can you please end the live stream?